Today's webinar is part of a series that we've developed, and it's based on a curriculum developed by Dr. Luis Sayas as part of our consultant group. And the title of the curriculum is Latinos and Suicide, a Clinician's Guide to Prevention and Intervention. Today is the first of a series of sessions. We'll be hosting the next sessions that include chapters 3, 4, and 5 of the curriculum on September 20th, 27th, and October 4th. So we are offering this series of webinars as part of the Suicide Prevention Awareness Month. September is Suicide Prevention Awareness Month, and it was developed to not only raise awareness on the often stigmatized topic of suicide, but also to prevent suicide by sharing information to communities, individuals, and professionals such as yourselves. So next slide. As you know, all of our products and trainings and presentations include person-centered language, which is non-judgmental, respectful, and consistent with our actions. Next slide. This presentation, as you know, our center is funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, and the information and the opinions that will be shared today with you do not directly reflect those of the Department of Health and Human Services or SAMHSA. Next slide. So I will tell you a little bit about our presenter, Dr. Luis Sayas, before we begin the presentation. Dr. Luis Sayas is Dean Professor and the Robert Lee Sutherland Chair in Mental Health and Social Policy at the Steve Hicks School of Social Work. He's a professor of psychiatry at the Dell Medical School of the University of Texas at Austin. Dr. Sayas is both a social worker and a developmental psychologist. His clinical work and research have focused on disadvantaged children and families, and he is the author of Latinas Attempting Suicide When Cultures, Families, and Daughters Collide, which was published in 2011. So I will leave you with Dr. Sayas. Thank you all.
Good afternoon. Good morning to some of you on the West Coast. Thank you very much, Dr. Orovich, for the introduction, and thank you again for the opportunity to be here and to talk about something that's a very vital part of the MHTTC's work, and of course the issues that we've got to consider when we're talking about mental health, that is suicide. And as you see on this slide, I have no conflicts of interest to disclose to you. And so with that, I'll proceed. And let's start first by looking at, our country, what it's being made up of these days. And what we have in effect is a country that is increasingly seeing more and more, oops, sorry, that's not supposed to have been. I've got this clutter on my screen that I can't get rid of. But there have been what we call, historic states where Hispanics have been known to be long before even the United States was the United States, places such as Texas. In the blue here, we have the traditional or the historic states where the population has been for a long, long time. In the red, you see more of the emerging states. Those are states where the population was not known historically to be there, but has grown over the past probably 2 decades, and is growing in numbers. Not only that, it's also diversifying. I'll tell you about that in the next slide. And then you see in the light blue or gray there, these are states where Latinos, Hispanics are now arriving in larger numbers. Down in Louisiana, we saw the growth of the Hispanic population right after Hurricane Katrina, when many Hondurans came to help rebuild the city of New Orleans. And also we've seen the places like Missouri and Wisconsin and places like that where it has grown more and more. So these are new arrival states. And even those states where you have historic populations such as Illinois and New York, it was such that in Illinois, for example, it was Chicago that was the primary center of arrivals. And in New York, it was New York City. But now we have large populations, in the case of Illinois, downstate Illinois, and in New York, upstate New York. So that really is really spanning out across the country. So we see that as clinicians, we are going to be seeing more and more the presence of Hispanics in our clinics and in our services. As I mentioned, it has been diversifying increasingly, the Hispanic population, but still Mexicans and Puerto Ricans are the two largest groups, 36 million in particular among Mexican Americans, and Puerto Ricans are about 5 million. So those are the two largest groups. But you see the growth of others in the 2 million mark, 2 million population area, the Salvadorans, Cubans, and Dominicans that has seen a considerable growth. Cubans also have been around a long time, since the 60s, late 50s, early 60s, when the first refugee group really began to come. And since that, we've seen folks from the Northern Triangle countries of El Salvador, Guatemala, and Honduras appearing now in the United States, and those numbers are growing. Interestingly, in this Pew Research Center slide, you also see Spaniards, that is people from Spain. While that doesn't typically represent Latin America, they are considered among the Hispanic groups because of their language of origin, Spanish, of course. And this is the situation now. The U.S. suicide rate in 2019 was 13.2 per persons per 100,000 in our country. But when adjusted for age, the Hispanic population, the actual suicide rate is at 7.3 per 100,000, or just a little over half of the U.S. rate. So it tells us that suicide is not that common among the Hispanic population. I have to stop here for a moment and ask our technical folks. I'm having trouble with the presence of a panel here on the left that's obscuring the vision, obscuring my slides. Is there anything we can do to change that? I presume not. But thank you very much for making it smaller, at least. That helps. So let me get back to the slide that I was at. In any event, the suicide rate is lower. We're talking about actual suicides, all right? And so the Hispanic population is not, it's less than half of the, rather a little bit over more than half of the total US rate. Of course, that includes whites, blacks, Asians, and any other group listed. Now, when we think about the age group, again, among Hispanics, the rates remain by age. The rates remain pretty steady across the lifespan, and this is a bit different for Hispanics than it is for the overall population, where we see the suicide risk most high, or higher rather, in the 35 to 65 range and upward. While we do have grave concerns about the number of adolescents that are dying by suicide, we do see here that still in the broader population, it is the adult population that is most likely. Although here in the 15 to 24-year-old group, you see that the rate is around 13% death by suicide in comparison to the Hispanic group, which is probably around 7-8% of the total population. So this gives you a sense of the suicide rates among the U.S. and it remains pretty level among Hispanics across the lifespan. But we are concerned, I am particularly concerned about adolescent suicides and suicide attempts. In this chart, we see also that the suicide rates for Hispanic populations by gender is pretty similar to the rate to the U.S. population. That is that that men are more likely to die by their hand than women, and also that the non-Hispanic male is more likely to complete suicide than the Hispanic male. You see overall from 2010 to 2019 that male Hispanics had a little over 10% of suicides, whereas the white, the overall U.S., not just white, the non-Hispanic group were in the low 20s. Again, we're seeing something about the rate of suicides is lower. How to explain that? We have to think there's issues of culture and religion that do mitigate against suicides in Hispanic populations. There's other values such as familismo, which is accounted for as one of the best protective factors among Hispanics. And familismo refers to the centrality of the family in the person's life and the importance of allegiance to the family. So we'll get more into that in a bit, but you can see again that the rates of suicides are lower. Now, when we turn to teenagers, the suicide attempt rate among Hispanic girls, adolescent Latinas, has been high for over the past 30 years. And I entered this field back in the early 80s and began to see this phenomenon as a clinician in New York City. And what we were seeing were young Latinas appearing at our emergency rooms following a suicide attempt. And as clinicians, we began to see the pattern over and over again. And when we would contact one another from different hospitals in different boroughs of New York, we saw the same pattern of Latinas being more likely to be brought into the hospital following a suicide attempt. So from the early 80s, or rather through the 1980s, as a clinician, I worked in this area, but there was no real research to go with. We did not have any research that would help us understand why it was the case, or if indeed what we were seeing in New York was just a local phenomenon or whether it was something national. And it was not until 1990, or rather 1991, when the Center for Disease Control and Prevention launched the risk behavior surveillance system for adolescents, that we began to see what was happening. And this surveillance system is of teenagers. It's administered during the school year, typically in the spring semester or the springtime, among a representative sample of high schools. And the children, the teenagers, are asked to fill out this form, which has many other risk factors, but my focus here is on suicide attempts. And so you see here what's happened since 1991, when it was first introduced. The Latina population were at about 11.6%, slightly higher than the others. Nothing that would have troubled us at the time. But if you look at 1993 and 1995, there was a real jump in the number, at almost 10% in the first year and about 3% the second year, 1995, in which Latinas outpaced all other youth in suicide attempts. And by the way, while this is comparing girls, the girls were more likely to attempt suicide than boys. And that trend continued throughout the 1990s and the early 2000s. But then we began to see something in 2017 in which the young African American girls were more likely to now attempt suicide, outpacing, in this case, the Hispanic girls, where Hispanic girls dropped. And that is something that we've got to look at. Why is it that that trend has changed? What is different now in the lives of African American girls that now raises their risk for suicide considerably by about 5% over the course of 4 years? And when we're talking about the millions of youth in the United States, that is a figure that really is worrisome. But we continue to see that for all of these 30 years. And I won't go into the African American experience at this point. That's not the topic of today's talk. It is about Latinas and Latino suicide. So that you can see why for many years I was very concerned about this and began to do research on it, and was finally funded by the National Institute of Health to be able to conduct this sort of research. But that gives you an idea that there is this troubling pattern of girls in Hispanic families attempting suicide more than any other group of girls, perhaps outside of Native American girls, particularly those on reservations. Now, as clinicians, you probably all know, I think we all know that a suicide typically is preceded by this pattern. First, we see sadness. As clinicians, we would see sadness, and this is what people report of their feelings mounting as they approach the idea of a suicide attempt. So it begins with sadness and hopelessness. And while this is characteristic to all suicide attempts, keep in mind that I'm now talking about adolescent girls, especially Latinas, but that there's sadness and hopelessness. Sadness associated with depression. The hopelessness is the despair of what will happen, to me. What hope do I have to live for? In the ideation, right? So we're talking about suicidal ideation, the thinking of suicide. The next step after that is to consider an attempt. The person begins to think about death and about killing themselves and how they might do it. And perhaps it never goes from there. Imagine that these 4 items are plotted on a scale. Sadness and hopelessness would be the highest, more frequent occurrence, and then seriously considering would be less, and then making a suicide attempt and the actual attempt. But many of us at some point in our lives have felt sad and hopeless, and perhaps we haven't even moved toward thinking about an attempt. Some of us perhaps have, but you see the progression. So the next step, as I say, would be seriously considering whether you really want to take your life or not, and how you might do that. It becomes more serious when a person begins to make the plan. Well, it's not just how I might do it, but this is how I would do it, because now I'm looking at what the opportunities are, how I would go about it, when I would go about it. The intentionality begins to grow, the planning begins to grow. And as clinicians, you know that you would be concerned with a child or anyone beginning to tell you that they're very serious about how they're going to take their lives, and perhaps describe to you a very full plan. And then, of course, the culmination is the attempt itself. In some cases, the attempt is finalized with death, right? It's an attempt that results in death, and that is ultimately the final step. But let's talk here about the girls who have attempted and have been able to report to us, and have not made attempts that are so lethal that they die. Although that, of course, is an issue. So this is the progression that we know by science and clinical experience. and human experience that leads up to the suicide attempt. Now, the data, the same data for 2019 that was provided by the Centers for Disease Control and Prevention shows this, that among girls in general, the sadness and hopelessness, remember that's the depression, that's the sense that I don't know where I'm going to go, where I'm going to be, is higher among girls than boys across all three white, Black, and Hispanic groups. But notice here that sadness and hopelessness in the 2019 cohort, these same data, by the way, are available for previous years, but I didn't plot them out. I just want to give you the year 2019. Now, just to back up a point, on the CDC survey, it's conducted on odd numbered years, and it's not reported till the following summer in the even numbered years. So 2021, the data have been collected, although because of COVID, we don't know how adequate that data is anymore. What we do know is that COVID has created more difficulties for kids' mental health than ever before. Here at the University of Texas, like many universities across the country, we have seen a spike in the mental health concerns of students on surveys about wellness and about campus climate and educational achievement. But we've seen a 30% increase in the concerns with their mental health. And we've also seen an increase in substance abuse. It's not just the University of Texas, it's across the country. But we do see that happening now, and it was exacerbated by COVID. We know that for sure because there was the students are telling us that. In the survey that the CDC does, the one that would have been done this past spring would have been affected by COVID. So we will see next summer what the 2021 data we're looking like when it comes to sadness and hopelessness. I would imagine that it's going to be higher than what we have here, where 50% of Latinas were feeling sad and hopeless, where 41% of African American girls and 46% of white girls were feeling this way. I think we're going to see this next year at a higher rate for both females and males. And you see here too that males are less likely to report sadness and hopelessness, but Hispanic males are more likely to report that they felt sad and hopeless in the preceding 2 weeks. Usually. Then we talk about seriously considering suicide, and here we have that in 2019 that Hispanic girls dropped, although only they were lower in proportion to African American and white girls. They indeed considered suicide. This is where ideation really grew, and they were talking about, or rather thinking about, taking their lives. So this survey is self-reported. It's a survey that the student completes in the classroom or at school at least. And so they are actually marking, yes, in the past 2 weeks, I seriously considered suicide. So this is about a quarter of our kids are girls, and about 10 to 11, 13% of the boys are reporting during the high school years that they thought about suicide, and that was in 2019. And again, I bring you back to 2021. 2021, when we have we will have been affected by COVID. Then there's the suicide plan, and here again in 2019, different from previous years where Hispanic girls were more likely to report a suicide plan, we see African American girls outpacing them by about 1%, less than 1%. So we can see that the suicide planning among all three groups of girls is still pretty high. It's 1 in 5 girls, effectively, in your high schools that are considering suicide or planning one. And that, of course, is something that troubles us if they are at that point. With COVID, we will see how what the response will be next year. Now, we do have we'll talk about the suicide attempts in a minute, but underlying the suicide attempts are some underlying reasons, right? These are the circumstances that the teenagers have told us that they struggle with over a long period of time. It typically isn't, a one afternoon blowout with a boyfriend, girlfriend, or parents. It's typically more things that are the teen is struggling with. We have heard from our research on girls, dysfunctional family issues were some of the problems. This was the most commonly reported: stuff at home, alcohol use by parents, substance abuse, marital discord, conflicts among family members, the divorce of parents, girls drinking or members of the families drinking, sexual abuse and molestation. Those are the reasons that may lead up to an attempt. And we hear those from the students. But then there's the trigger, right? What triggers the attempt? And this is typically an event that occurs shortly before the suicide attempt, essay in this slide. That's the suicide attempt, in which the girl tells us, the clinicians or the researcher, that it was directly related to her suicide attempt. The most commonly reported ones are that there was a relational conflict with a family member, mom, dad, sibling, a sweetheart, whether it's a male or female, that is a partner. Perhaps sweetheart is an old term, but it's a boyfriend, girlfriend, a loved one, or at least a romantic attachment, a problem with a friend or other close person. For example, we heard of that, say a favorite aunt moved away and was not available for that person, for this adolescent, that might have been one of the triggers when she realized she was alone and something happened with her family. And what happens is that the emotional experience of those triggers is difficult for the girl to deal with. And we're going to talk about the development or the lack of development of coping skills that lead to suicide attempts. But in this case, the girl has trouble dealing with the complex feelings in her life of whatever it was that triggered it and the underlying reasons that were behind it. And then that there's this escalation, this frustration and tension that build. In our research, we learned from the girls that the suicide attempt, the moment of the attempt, was not a one-time thing. It had been building. Their tensions were building. There was prolonged and intense stress with family members, a breakup with a partner, but that the moment of the trigger was almost emblematic of everything that had happened before. It was like in that one moment, their entire struggle was encapsulated in their pain. That is, it was the one event that just built on so many others. We could call it the straw that broke the camel's back, or the last straw. We could call it any number of things, but the girls were telling us that it was almost a reflection of it was like a microcosm of everything that had happened before, and it reminded them of so many other painful times in the past that then they made the attempt. So that was part of the trigger. It wasn't just one event. It was a buildup of the events of incidents and events in the past that were based on that underlying reason for the suicide attempt. And so this is what has happened. Then in 2019, with those kinds of underlying reasons and triggers, we see the suicide attempt. In recent history, in those 30 years of data collection by the CDC, African American girls were never anywhere near 15%. They were closer to the white girl there in this slide at about 9.4, 10, 11%, where it was the Latinas who were up at 15% in most instances, so about 1 in 6. And now we see 1 in 6 girls, African American girls, attempting suicide. Note too that among the males, the same pattern has come up. and there has been a recession in the suicide attempts among Hispanic girls. That's something we've got to try to understand. It's a good sign, at least for the Latinos, but we have to be concerned about all of our kids, and we would need to be concerned about what's happening with African American girls. Incidentally, it might very well be that an African American girl may also be a Latina. She could be an Afro-Latina. It depends on how she marks her her survey as to her race and ethnicity. So that's that. So we see the progression and how it builds up to a suicide attempt. Over the years, through our research and through clinical experience, we've developed this conceptual model. It really goes back. It was published in 2011 in the book, but it was one that we first published in 2005 after much consideration of the factors. And so my team and I came up with this sort of pathway that's actually been tested by several studies, dissertations in particular, and is shown to be an accurate representation of what happens. So you have to think about the family socio-cultural environment. And that's the family, right? That's where the family lives, how the family lives, you know, the context in which they live, the social, the cultural, the physical and geographic environment of where they are. And within that environment, we focused on three elements to the suicide attempt. One was the girl's development. Suicide attempts by girls are most likely to happen at the age of 14. That's generally the time of the attempt. There are girls who attempt earlier. There are those who attempt later, but the average is 14, 15 years old for that attempt. And so we're thinking about adolescent development. I'm going to go into that a little deeper in the next couple of slides, but keep that in mind. We know something about the Sturm and Drang of adolescent development, and it's no different for Latinas in their lives. We have to look at the cultural traditions that they have and their families bring. So these are the sort of beliefs, the values, the behaviors that are associated with Hispanic cultures, not just one. They may differ, but there are some generalities across the cultures, the different regional groups that would allow us to generalize to some extent about cultural traditions. And then there's the family's functioning, right? How well is this family functioning? Remember earlier in the slides I talked about that some of the underlying reasons were this dysfunction in the family, alcoholism, and so on. And in this case too, the girl is growing up within this environment in which the family is functioning adequately or not. Now those things together are part of the day-to-day lives. Then we have to think about, so there's the family and then the psychological functioning of the girl. Here we're talking about coping skills, judgment, reasoning, impulse control, emotional regulation, all sorts of things. How well is this girl functioning? And in the model towards a suicide attempt, we detect that there's an emotional vulnerability that comes out of that social cultural environment in which she has grown, and that leaves her susceptible to the impact of some kind of trigger, which you see here in the horizontal rectangle, and that interpersonal conflict. Remember, it could be boyfriend or girlfriend, parents, sibling, any number of people in their lives. So that interpersonal conflict is the trigger. And then when the girl experiences that trigger and what the conflict is, we call it the subjective experience of that crisis. And that leads to the frustration, the tension, and the attempt. Now, we can think about it. This is what leads to the suicide attempt. We could also apply this to a girl who doesn't attempt suicide, and we would be able to say, so what is the family social cultural environment? Then what's her psychological functioning? And when she is under all of this stress, what is her subjective experience? And she might come out at the other end well. She may not attempt suicide. So that is a model that helps us in both ways to understand it. And in the Q&A, I'm happy to come back to this to cover it more with you. Now, let's talk about culture, those cultural traditions that we talked about. We're talking about the intergenerational stressors of children and their parents. Look down at the fourth or fifth point there, the acculturation gap. We're talking about oftentimes that the suicide attempter is often either a second generation girl or a first generation girl of immigrant parents. And what we have found is that when a child, when one of these girls arrives in the United States at a very tender age, say under 5 or 7 or so, that she is more likely remaining in the United States to acculturate more rapidly, so that by the age of 13 or 14, she looks far more like the Hispanic girl who was born here, the first generation girl. And so that they look alike because they spend a lot of time in the US. However, we have found in our research and in others that when a girl arrives later in her life, and we're talking about the 11, 12, 13, 14-year-old, when she's a teenager or older, she's already more enculturated to their culture of origin, and that provides a protective buffer. And the differences in that acculturation gap are less between her and her parents. So we know, something about culture, family values, attitudes, the interactions. And again, I'm going to come back to adolescent development, and within that, the acculturation gap. Now, one of the ways we've approached the understanding of suicide attempts is to look at the developmental systems theory, is to use that. And in there, we know that there's a reciprocal interaction between the person and the environment. It's not, a suicide attempt is not solely an environmental factor, nor is it entirely an internal or intrapsychic process. It's really an interaction between the two. And we know about ecological systems models that we perhaps are formed, if you will, in a microsystem, and then we enter schools, and there are mesosystems and exosystems and macrosystems affecting us. So in developmental systems theory, we are thinking about the person in their environment and the reciprocal interaction between the two. That was a way for us to understand how it is that the suicide attempt comes about. I want to draw your attention here to the bottom line, which is the zone of proximal development. Really, that might be a point that could be on the cultural development side, because really the zone of proximal development, Lev Vygotsky, the Russian psychologist, coined that term, is truly the very microcosmic interaction between the parent and the child. That is the growing child from birth, right, cuddled at home and taken care of and protected. But all of that interaction is happening in that microsystem. And Vygotsky thought that it is within that zone of proximal development, that very close tie, that culture is really transmitted. And it begins at the earliest stages of life, about how a child is handled, how a child is treated, and what's expected of the child. And those messages come from within the family early on. Not only is it a cultural factor, but it's also part of the family's functioning, how well they handle that child and how well that child feels handled or taken care of within that environment. We know about the so-called good enough parenting, especially in early childhood. That would be part of the factor within the zone of proximal development that Vygotsky outlined. Now, remember that in that family sociocultural environment, we talk about adolescent development. What we have there, really, when we think about adolescence, I point out the two of the primary issues in the development. Now, I say development because we're talking about psychological. Maturation is a different matter, right? Maturation is more of the physical development into puberty and beyond. But in adolescence, we're talking about the development of the person, the personality, and the mind. And what we do have in adolescence, with, again, in tandem with maturation, is the desire for autonomy. The adolescent wants to be more herself or himself, wants to be able to make decisions, think for themselves, act for themselves, establish new relationships outside of the home, but still recognizing, however unconscious, that there's a connection to a family. While they wish to be independent, there's still a desire to relate, to remain connected to family. And this is especially so in Hispanic families, where the value of familismo is so present, and part of the development of the identity is that one is a member of the family, and family, essentially, family comes first. So we are going to be talking also about the adolescence development is taking place within this cultural tradition and within a family, within the functioning of a family. And what we have found in the research is that, and we've used family systems theory to be able to, as a microscope into families, is that we know that family systems, well-functioning families, are able to manage these three concepts here, or these three processes: cohesiveness, which is, of course, togetherness, and the capacity to maintain external boundaries around the family that keep the family working together, remaining together, identifying as a family together, and things like that. That's part of the cohesiveness. But also, families need to be able to balance that cohesiveness with adaptability. So it's really a matter of how well are families maintaining the desire to keep the family intact and together and functioning well, but how adaptive is it? How adaptable is it to the natural maturational process and development of their children? So easy enough for us to understand, a family will handle a 5-year-old very differently than a 15-year-old. The cohesiveness, adaptability balance needs to be managed differently, because at 5, we don't expect the child to leave the home and be able to do things for themselves with that we might expect of a 15-year-old who goes to school with friends, might take his bike ride, and by the age of 16 have a driver's license perhaps to drive to school. And that family has to begin to adapt. How closely do we keep our kids based on their maturation and development? And so that is an important balance. When we have families high in cohesiveness and low in adaptability, then we have a closed system, right? More of an entrenched family. If we have a family that's highly adaptable and not sufficiently cohesive, we have the disenfranchised family, the family that's just, doesn't see itself as a unit. So the balance between these two is so important for good family functioning. And this is all carried out through communication. How we communicate with our children, between parents, one parent and children, and the other parent and children, and across children. And we know that the subsystems that form among family members could be beneficial to family, could be toxic to families, especially when the parental dyad is in some way weakened or disrupted, or parents align themselves more with kids than others against, say, either another sibling or against the other parent. Then we know that that's when families begin to break down. I mentioned the psychological characteristics of the girl in the conceptual model about the emotional vulnerability. And here we're talking we're talking about the innate characteristics that have been developed by the girl within that zone of proximal development. What she has acquired, her coping skills, her regulation, is not just an internal process, it's part of what she learned at home. And we do know that among suicide attempters, there is low frustration tolerance and some impulsivity, sometimes a lot of impulsivity. We do know that among the suicide attempters, depression and anxiety are often higher than other girls, non-attempters. Personality disorder, sometimes with underlying some mental illness, is present in many of the attempters. And we have to always account for past physical and sexual abuse. So those are aspects that might have happened in that family sociocultural environment, or even outside of it. So, the abuse might have been from a non-family member, but depending how the family handled it, that will determine how able she is to cope with the stresses and strains of adolescent living and life in general. Childhood adversities are part of what we need to think about when we think about suicide attempts. It's one of the most robust predictors of suicidal behaviors. What's happened to children? You've heard of the ASA, kind of the adverse childhood experiences, and the more they pile on, the worse the outcome. And the risk for a suicide attempt can be 2 to 3 times higher when these childhood adversities mount. Some of those adversities could be in the home. In the case of more recent immigrants, we may see some of the immigration experiences and the maltreatment by coyotes and groups that have been helping families get into the country, or even at the hands of U.S. Customs Enforcement. Those sorts of adversities could rise there as well. So with as children endorse more of these adversities, their risk of suicide attempts grows. And of course, childhood abuse is the adversity that's present, that presents the greatest risk of all. So that again, that family sociocultural environment is vital to understanding the suicide attempt. One of the things we've seen, and this may help us understand why it is that African American youth are now attempting suicide more often than others than has been in the past. We do know that when you witness death, when you see a dead body, or when you see somebody who's been seriously injured at the moment of the injury, we do know that the largest part of the burden in PTSD is the experience of witnessing a dead body, and not at a funeral home, but I'm talking about a dead body on the street, witnessing someone being killed or seriously injured. And those experiences affect the memory and of within PTSD, and that's where we get kind of the vivid, intrusive recall of those memories. And again, as with more distress and more frequent exposure to those, then the higher the level of PTSD, and the greater the burden of PTSD and the possible suicide attempts. And so I mentioned about African American youth now growing in number. We might consider whether, the past 5 years or more, when we've begun to see more and more videos repeated in which mostly African American men, but women also and children have been killed by police and by other people, and it's been caught on camera. Those daily reminders could be adding to the burden of youth and leaving them more anxious, sad, hopeless, and perhaps contemplating suicide. My chances of dying are greater now than ever before. So why don't I just kill myself? I'd like to. Oh, I'm sorry. We've got there are some missing slides here, so I'm going to have to improvise at this moment to go through this. We have found that these suicide attempts by Latinas are very frequent. In our research, we found that one of the determinants of a suicide attempt, one of the greatest among Hispanic girls, was the level of the quality of the relationship between mothers and their daughters, or daughters and mothers. And what we found was that the girls who endorsed a strong relationship with their moms a strong and positive relationship were less likely to attempt suicide than those girls who felt that their mothers couldn't listen to them, didn't listen to them, were unable to pay attention, or mothers who needed the girls to take care of them rather than they taking care of their daughters. And I think that's really an important aspect. Now, there were some interesting findings in our research. We asked both the mother and the daughter about the relationship, asking them identical question. When you want to talk about yourself or about something, your mother is likely to respond in which ways? And then they've got a selection. And a mom is asked, when your daughter wants to talk to you about these same three things, how are you more likely to react? And again, those the same responses. So what you do is then you check how concordant are they. Now, what's interesting is that both girls, suicide attempters and non-attempters, reported that that their mothers were not quite as empathic and understanding as they would like. Now, the difference was that adolescent who had attempted suicide felt more discordant with their moms than non-attempters, but it wasn't a statistically significant difference. On the other side, we found that both sets of moms reported that they were really attuned to their daughters' feelings and that they were always there and open to them. Then when we asked the girls, how attuned is your mom to you? We did see a big difference. The non-attempters were saying, well, she really doesn't understand me. She doesn't get me, but she's trying. Or she gets me sometimes and not others. So you see that there's some level of mutuality and reciprocity, not great, not ideal, but better. Where in the suicide attempters, these girls were reporting, my mom thinks she can, but she doesn't have a clue. She doesn't understand. She doesn't seem to try to understand why it is that we don't have the kind of friendship and bonding that she thinks we have. So, and the correlation was that the more mutuality, the better that relationship. Or let me restate that with a strong mother-daughter relationship, with respect to mutuality and reciprocity, the risk of a suicide attempt dropped by 50% on the scale that we were using. So as a girl and her mom, with every one step indicating that they were reciprocal and interactive and had a good connection, with every one tick on that instrument, we found a 50% drop in the likelihood of a suicide attempt. That goes to show you how vital that relationship is. We did study fathers as well, but we didn't have enough of a sizable sample to really be able to state what effect that relationship would have on girls. It's just simply too small. But we did hear that girls felt that fathers, they had more mutuality with their fathers than with their moms. But we found that to be a pretty spurious kind of finding. It was, again, the sample was too small. But what we did hear was that, or rather what we did understand is that the moms spent much more time with their daughters, so that their relationship was spending more time together than the girl and her dad. So dad could be very supportive in those few minutes or few hours that he spent with his daughter, whereas mom had the other 23 hours a day to work with her daughter on bad hair days and when she didn't want to do chores or whatever the case might be. And so those relationships were more vital. We also found that when parents were more adaptable, remember adaptiveness and cohesiveness, the adaptability of the parents reduced the chance of a suicide attempt. So for example, in the case of one family, the daughter wanted to date. And this was not a question of romance, but rather an exercise of autonomy. She wanted to be able to date this young boy in the neighborhood. And so she's telling our interviewers, or the parents are saying that they didn't want her to see this boy. They thought at 14, she should not be dating because in their home country of Colombia at that age, in their particular uh, town of origin, that didn't happen. You didn't date until later, and when you did, you dated with a kind of greater level of commitment. But these parents understood that they were now in the US. It was a very different system. Their daughter was a freshman, and it was different in the US, and that there were different pressures. So this very adaptive and adaptable set of parents decided, well, the last thing we want is for her to start sneaking out and seeing him, and who knows what that would bring. So why don't we let her see this boy, but have the boy come to our house, and he can visit with her there, and they can sit in the living room or at the kitchen table and do homework together, and that would be the way. Well, they instituted that, and after a while, the little relationship broke up. But that was a way of them being able to manage the situation in a way that would not have led their daughter to attempt suicide. And those are the sorts of things. We had cases, severe cases of girls who had attempted suicide where parents were very intrusive in their lives, including a father who was a retired detective and would follow her to school and would essentially surveil her, sit in surveillance from his car to make sure she wasn't seeing other boys. But she was well aware of his protectiveness and his overreaching, so that in a family system where there was a greater level of enmeshment, and in which he, the father, was creating kind of these constraints on his daughter that didn't allow for her to experience the developmental needs that she had. And she was one who attempted suicide. In another case of a suicide attempt, the girl, the mom had a new boyfriend, and so they went to visit the boyfriend's family in another state. And while there, the mom's boyfriend's cousin attempted to molest her or to assault her. And when she told her mother said, "Oh, you're just trying to break me up. You're saying that just so that I can break up with my boyfriend." Not with no capacity to understand what was happening to her daughter, but instead what was happening to herself. And so you can see where the mutuality and the reciprocity can fail. Let me turn a moment to interventions, although some of that will be covered in subsequent webinars. But I think we need to think with this model that I've presented and the findings that we have, that it really family-oriented interventions are really what we need to think about. How do we assess families, Hispanic families, where there's a potential for suicide or where there has been a suicide attempt? How it is that families need to work. The idea of separating the adolescent and doing individual therapy and leaving the family out is frankly going to be a very long and useless or limited endeavor. We need to bring families in. There is research showing that in Puerto Rico, for example, the adolescent expects the family to be engaged in the therapy because there are issues there with the family, and that the therapist must adapt to that. And we do know that that tends to work. In schools, we need to think about, especially with this generation gap between the parents, that the acculturation gap, kids are acculturating much more rapidly than their parents. That's on top of the generation gap that we all know about between parents and children. I think we need to help, especially immigrant parents, understand their child's developmental experiences and what they're facing in the US that's different from their own countries, so that parents understand why their children are doing what they're doing and can then develop the adaptive skills or reset, if you will, their parenting skills, some of the values, so that they can do better. Then there's on the other side, we also have to help the adolescent understand why your immigrant parents are the way they are. One of the things that I have found in clinical work in the past is that families have lost their ways. For the parents do not necessarily tell their children about their experiences in Guatemala, Honduras, Cuba, the Dominican Republic as kids. And so the children don't have a context of where their parents are coming from. And in family interventions, we can open up that level of communication. In the mutuality scale, it's really about how well does a mom and a daughter communicate. In this case, we can talk about parents and daughters communicating. That the more communication there is, and the storytelling of the past is so vital for a child to feel part of the family, and they can then understand why their parents are the way they are. And I think it's important in that therapy that the child has to be helped by the therapist to listen, and the parents have to be helped by the therapist to listen to their child. I want to make sure we allow enough time for our Q&A. So I will stop there.
Thank you, Dr. Sayas. Thank you for a great presentation. We have a few questions. The first one is, you mentioned the role of religion and spirituality as a protective factor. In your experience, what role does religion and spirituality play after a family member or a community member dies by suicide?
This is, it's always difficult to talk politics and religion because let me start on something I know more about, which is the role of religion in the families of girls who attempted suicide. And it wasn't so much the religion itself or the level of spirituality. It was the manner in which the girls perceived their family insisting that they participate in religious services. So let me give you an idea. We had girls in our sample who attempted suicide who felt that their parents were just simply not reasonable about the expectation around religion and religious services, so that the girl had to dress a certain way, had to attend church services 2 or 3 nights a week, in spite of the fact that she had homework to do, and that sort of and participate actively. We had other families who insisted that their children participate in religion, but they were able to do it such that there were other teenagers there, so they could separate out, and the teenagers could enjoy themselves together within a religious and spiritual context, but at least as teenagers, and that's the kind of balance. The unfortunate thing that I have seen, and I don't know the research on this, but is that too often the person who's died by suicide is considered vilified, if you will, for having kind of the worst of all sins, which is to kill oneself. And no matter what, the surviving family members hear that, have to deal with that, and that can be very painful. So I don't presume to say that religion causes it, nor that religion can can prevent it, rather. But more like how do we help the family through in a religious community to make sense of the death, to mourn the loss without feeling that my child or whoever the family member was that attempted suicide is a sinner and is now in hell for having taken their own, or that they don't feel that they are to blame. So I think it's the religious group has to come around to try to help people heal, and not to place blame or guilt or shame on others, but to really help them understand. And we do know that many enlightened pastors will turn to mental health professionals to help families. So I hope that answers at least part of the question.
Mm-hmm. Thank you. Yes, it does. Thank you. We have another question. What would you say could you speak more about acculturation as a possible stressor for vulnerable Latinas?
Oh, absolutely. Be happy to. First, let's talk about what acculturation is. Acculturation is really the movement of the adaptation to and adoption of elements of the mainstream culture. So when you come from another culture, whether you're coming from Ghana, Kenya, Vietnam or any other from Bolivia or Guatemala to the United States, you're going through a process of acculturation. That is, you're acculturating to the mainstream culture of the United States. Now, you heard me use the term enculturation. That's the culture that you grow up in. So whether those countries I mentioned, Vietnam or Guatemala, when you're growing up in those countries, you're being enculturated in it. Now, when you arrive at a new one, you've got acculturation through the new system. And what we do know, and research since I was a graduate student a long time ago, shows that children acculturate more rapidly than parents do to the mainstream culture. Just like children learn the language much more rapidly than the parents do. So that acculturation rate begins to create tensions in a family when the children are ready to be engaged in the mainstream culture. Their parents are not quite as engaged or as ready to engage, and are uncertain about how they want their children to engage. So with acculturation comes changes in values and socialization practices and behaviors. So one of the key things in the work that I've done with the girls has been that of the acculturation to new gender roles. How is it that the girl was, what her parents, what socialization, gender socialization, the parents, the parents bring from their countries of origin, their cultures of origin, and what do they expect their daughter, who is now being exposed to a different experience of womanhood and being a woman. And that's where the acculturation differences could create difficulties. That's perhaps one of the most severe, but it does happen with respect to attitudes. We do know that, for example, with acculturation, the children will be less or report less familistic values than the parents, and the more acculturation, the further they are. So those are where conflicts can emerge, and we see it when the teenager especially wants to do something and the parents are saying no, and we see the cultural or acculturational differences. I'm happy to answer more, but I hope that clarifies where the tensions come from, where the children will want to do things that their parents are not yet ready for them to do, if they're ever ready.
Thank you. Yes, it does clarify. We have another question. Is there any research that looks at variables of discrimination or bias towards our youth that may lead or increase the chance of suicide attempts?
What a wonderful question. And I hope that whoever wrote that question is a researcher and will pursue it in her or his dissertation or in the research in the future. That is a good question. We don't know. We do know how much it affects mental health. That is, what we call microaggressions, or even, kind of even worse, direct physical aggression, name calling, discrimination, bias, does tax our mental health. We do know that the discrimination, the day-to-day impact of slurs and comments and physical gestures, sometimes, when you're left to feel like you're invisible in a group. Professionally, I've been in settings where a minority person, including me, says something, it's almost as though it's unheard, or that is, no one heard it, and then later someone says the same thing, but they're heard. So those do affect us. Those kind of stresses do affect our mental health. In our research with the young girls, we did not hear any of them say that that the peer group was the reason for their attempt, or that discrimination was a reason for their attempt. But I have to give you a caveat with that. First, the girls that we studied were primarily in Hispanic neighborhoods in 4 of the 5 boroughs of New York City. So, while they faced discrimination, their more day-to-day experience was within their communities. So that was one of the things. But the girls did say that it was more family, so it wasn't peer. But I do know that it does affect our mental health. To what extent it leads to a suicide attempt That's a question. That's a great question for future research.
Thank you so much. Your presentation has focused on young Latinas. What would you say about Latino adults in comparison to other groups?
Well, as you saw in that one of the early slides, the Hispanic population in general completes suicide much less than other kind of the total U.S. population. So we do know that it is not as common. Could you please repeat the question? I lost track.
Can you speak on rates of suicide attempts among Latino adults as compared to other? No, it says as compared to different Latino subgroups.
Oh, now you're asking, yes. Amongst Latino subgroups, that's harder to do. What we do know is those studies, for example, the surveys are national. And so when you see the rates that are shown by the CDC there in the opening slides, those are respondents from around the country, which means that if the responses came from the Southwest, chances are the majority of those would be people of Mexican descent. That's not to say there aren't others. There are Puerto Ricans in Arizona and Cubans in California, you know, and what have you, Dominicans in the Rio Grande Valley of Texas. But the majority are Mexican. In other parts of the country, in South Florida, you'll see more Cubans, Nicaraguans, those from the Caribbean and Venezuela. And then, of course, in the Northeast, Puerto Ricans, Dominicans. And so what we do know is that those are steady. Now, I don't know anyone who's doing intra-ethnic differences in rate. That would be useful to know. In my more recent work, we have seen the suicides primarily of men in detention centers, in immigration detention centers. The few cases that I have come across have been fathers whose children were removed in 2018 and suicided within their prison cells. They're not prisons; they're called detention centers, but they are prisons. But in only one case that I hear of a mother of a woman who committed suicide, who suicided in immigration detention. You know how it is that that each gender handles the stresses. Now, in one of those cases of the men that I was directly involved with the boy, he was incarcerated or detained with his son. His son was in the same room, and the father went to another cell or nearby bathroom and asphyxiated himself or hung himself. But in the other cases, it was the despondency of having lost a child separated during the family separation of 2018. I'm just giving you a sliver of what I know about this. That is, you know, there's much more, but those have been my experiences. But you know, suicide is universal. There's no culture that's immune to it, that has more of it or less of it. We do know lately that in China, women in their 20s and 30s have the highest rates of completed suicides, especially those in rural areas. And you can look at the sociology or the social context in which they are, where in China, in rural China, if you're not married, you're considered to be a drain rather than an asset. It's also very much known that the male gendered, the male child is valued more. So there we can see some differences in gender within a culture. But across the Latino groups, I think it would be interesting to learn where the differences are and whether it's related to kind of national origin. Is it related to other things, social class, or the experiences of immigration, those who had it harder, those who had it easier to come in? We don't know, but it's a really good question. And I hope that people listening and those who will listen in the future who are looking for a topic to do research in might follow up on that. Thank you.
Thank you, great. Okay, so we spoke about acculturation. Now we have a question regarding assimilation and its possible impact on suicide or suicide attempts.
Oh gosh, that's a tough one, and I would have to, beg off in a sense, because I haven't done that sort of research, and I've not looked at it in the context of the suicide attempts or even the suicides. But let me tell you, I can speak from the clinical side, having seen a few cases in which it seemed to me that the assimilation or the acculturation was so high, so fully immersed in the new culture, that it left people isolated and without skills on managing the challenges they face. So in the case of one man, and in a different case, a family, the family had come from I think it was Puerto Rico in this case, and had bought in entirely to being Americanos. We are, it's like English, and we were gonna, let go of many of our customs and be fully assimilated. We're gonna be Americans. And the problem with that was that the family had no real history to fall back on, because they had abandoned their earlier and had fully assimilated to the new culture. And so when their children were facing these challenges in their lives, the family didn't have a history, or parents didn't know how to respond, because they were not, kind of originally of the culture that they had now adopted, or swallowed hook, line, and sinker. And that created a problem. In the other case, it was of a Cuban man who I treated for depression, not so much for suicide, but deep depression. And it came after a drunken stupor in which he got on stage at a concert by a Cuban folkloric group. And something happened as he got drunk, and he was bounced from the place, and his family brought him. And his concern to me was that he had really just, as he said, sold out, and he should have kept more of his Cuban ancestry and identity and self in a way that he hadn't. And that night, I guess it touched something very deep in him and caused him to create a problem at the concert or venue, whatever it was, and then being brought to me. So I can only speak from those, and it's troubling. If you think about families, let's talk about families and our own identities, right? So families provide us with the roots of who we are. It's our identity, right? So we can go around and say, oh yeah, I'm Puerto Rican, or I'm Dominican Puerto Rican, or I'm fully Dominican, or I'm Mexican, Guatemalan, because our parents are. Many of my friends talk about their Irish, Scottish, German ancestry. There's something very anchoring about that, right? So there's even the music of the culture, the cuisine of that culture. We don't just eat the food because it's good for us, because it tastes good, but it brings something else back. There's a psychological part which connects us to our identity as a person of that culture. So that's closeness, even among the bicultural kids here, or what we call now ambicultural, those who are further along in generations from their origins, where they choose to come in and out of the two cultures. They may not be bicultural fully, but they can dabble, if you will, and that gives them a great sense. That's really vital. The other thing we found is that when families maintain rituals, that is, rituals around storytelling, parties, dinners, where it tells people, kind of those of us looking into the family, that this is kind of the identity of this family. So you have families that that have a Tio Pepe who was known to tell salty jokes at dinner tables, but everybody loved Tio Pepe, and it was important to have him at the table and the memories of him. And remember when we used to all do this, and maybe repeat some of those rituals. Rituals are very nourishing for families, because again, it brings people to a common sense of identity and experience. It's different from routines. I take the garbage out every Thursday evening, as I will tonight, so that they can pick up the next morning. That's a routine. That's not a ritual. The rituals have to do with how we interact with each other at dinner times and at holidays that are uniquely our family. And so I do think that if we think about antidotes to a sense of alienation or loneliness, of lack of belonging, I think we have to re-nourish people with their cultural family identity, even if it wasn't the best family in the world. That there are ways to take the good and be able to use it to help us thrive and have better or improved mental health.
Great, thank you. I think we have time for one more question. In your experience, are there cultural aspects that keep many Latinos from talking about suicide, and what are those?
I think there's still, as many cultures, the stigma around suicide and death. And, there's always the sense that if you talk about it, you're only coaxing it to come to be. In a different context, I recall running focus groups of elderly around living wills and healthcare proxies. And when we were asking, so, which child would you turn to? How would you begin to think about what would happen to you should you go into a nursing home and hospice, what you would want done? Can you bring that up with your children? And the word was no, 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 no. We don't want to, because just the mere talk of death could just bring it on. The other reason was that they didn't want the children fighting among one another as to who would have the decision, who would be have the power of attorney. That's that sort of similarity in talking about it means you might bring it on, or you might really propel it. However, suicide really needs to be discussed when that person feels it. And we need to ask, as teachers, ask our kids if they're showing some despondencies, or school social worker or guidance counselor or psychologist, so have you ever thought about this? There's nothing wrong with asking, and it doesn't mean that we will incite it. We would have to caution about how parents will ask that and how much we encourage parents, because it depends on the tone, the context, and the past history between a parent and a child to raise the issue about self-harm, because it's different from an empathic, warm, I hope you're not thinking of hurting yourself, or if you have, it would really, I need to know because I want to help you, versus don't tell me that you're going to attempt suicide, or tell me if you are. You can just see just by my tone the differences. And I think that has to be really well coached to discuss suicide attempts. And sometimes in the classroom, the quietest kid may be the most at-risk child. And so just as much as the actor out might be troubling in a classroom and be displaying some mental health problems, it's that girl in the corner who's quiet and does her homework and presents it, who might be having more trouble and could be the next suicide attempt at the school.
Thank you so much for your answers. I think this is a great way to end the webinar, as we are again creating awareness on the topic, the importance of speaking about it. And now that we are at this month, which is the Suicide Prevention Awareness Month, I think it's really pertinent to speak about these issues. So on behalf of the center, again, I want to thank Dr. Sayas for a wonderful presentation, and let our audience know that once again that this is the first session of a master series that we'll be conducting throughout the month of September and the beginning of October. And the next presentation will be on September 20th. And on that presentation, Dr. Jesse Rocky Romero will be presenting on discussing risk and protective factors for suicidal behaviors among Latinos. So we invite you to join us at the end of the fourth session. Those of you who attend all of the sessions will receive a certificate of participation. So again, thank you all for joining us, and we are happy to have you and to see you again. Take care.